Hello, I wish you good health and will try to deliver you part 2 of the gynecopathology lecture, so pathology of the female genital tract part 2. We stopped with the endometrial pathology, part 1 finished with endometrial pathology, but the uterine corpus has also the myometrium, and at least two further pathologic conditions need to be mentioned. One of them is leiomyoma, which is a benign tumor of smooth muscle cells. They are the most common benign tumors in females. They can be found in nearly half of women during reproductive life. As the tissues involved are hormonally sensitive tissues, smooth muscle cells, these tumors have a tendency to growth due to estrogen stimulus. So during reproductive life they grow, but after the menopause they tend to shrink if left in situ and not removed surgically. Leiomyomas are grossly circumscribed, firm gray-white masses with a whorled cut surface. They may be solitary, but more often they are multiple. And with aging of the patient and the lesion, they can become densely collagenous, hyalinized, and may even calcify. Microscopically, normal-looking smooth muscle cells are arranged in whirling bundles, and sometimes we identify degenerative changes like hyalinization, calcification within these lesions. Leiomyomas may be asymptomatic, discovered by chance, but they may also cause menorrhage and menorrhagia or metrorrhea as symptoms, bleeding from the uterine corpus. Menorrhagia refers to menstrual cycle associated bleeding, whereas metrorrhea is just referring to the site of bleeding, so bleeding from the uterus without referring to the cycle. They may just be seen as pelvic masses or may be detected as a cause of investigation of infertility. They have no potential for malignant transformation. Remember this. I will probably mention this later on as well. This is an example of a solitary leiomyoma. You can appreciate the uterus. Here is the uterine cavity, the endometrium here. And the uterus normally would be of this size, and this is much enlarged in size due to the presence of a leiomyoma in the wall of the uterus. So leiomyomas may be located submucosally, and then they more often cause bleeding disorders. They may be intramural. If such a big lesion is at the internal orifice of the fallopian tube, it may completely block or at least narrow the lumen of the fallopian tube, and sometimes, rarely, they can arise subserosally on the surface and bulge out of the contours of the uterus. Histology of the leiomyoma shows smooth muscle cells arranged in a whirling fashion. There are no necrotic areas, no mitotic activity or very low mitotic activity. The malignant counterpart of leiomyomas is the leiomyosarcoma, which is a malignant tumor of smooth muscle cell origin or differentiation. These tumors tend to occur in postmenopausal women, so later in age. They are relatively rare. Although leiomyomas are common tumors, leiomyosarcomas are rare tumors. Grossly, they are not firm but soft, often hemorrhagic, so red or brown, necrotic yellowish discoloration showing masses in the myometrium. The criteria for diagnosing a smooth muscle tumor as malignant in the uterus include the presence of tumor necrosis, this is a very important feature, cytological atypia, and increased mitotic activity. This is the histology of a leiomyosarcoma. You can appreciate at least 1, 2, and maybe a third mitotic figure here. And you can also distinguish between large nucleated cells, smaller nuclei. So there is some pleomorphism in the cells that compose this tumor. Of course, depending on the grade, this may be more and more atypical with increasing grade. Leiomyosarcomas are primary tumors in the myometrium, and they never derive from pre-existing leiomyomas. This must be kept in mind. They are solitary tumors, and although they are solitary, the presence of a myometrium involving leiomyoma does not exclude the possibility of a distinct leiomyosarcoma. Recurrence is common after removal. Metastases develop in the lung, and they are also common features of these malignant tumors. And the higher the grade, so the more anaplastic the tumor is, the poorer the prognosis. Fallopian tube pathology we'll discuss briefly, and I will include ectopic pregnancy in this part of the lecture and referring to it later on. Inflammation of the fallopian tubes is called salpingitis. Salpingitis is part of pelvic inflammatory disease, or PID. Most of the cases involve gonococcal infection in the etiology, so the most common cause of salpingitis is gonorrhea. The rest is referred to as non-gonococcal salpingitis, most commonly caused by Chlamydia trachomatis, but also some other bacteria, or including Mycoplasma and other intracellular pathogen. These salpingitises are acute purulent inflammations, and they turn to become chronic purulent inflammations later on. They can lead to blood-borne infections, dissemination, causing metastatic abscesses, sepsis, but very commonly they are sealed off and form tubo-ovarian abscesses. Adhesions may form, blockage of the tubal orifice may occur, and therefore there is a predisposition for sterility and ectopic pregnancy in the fallopian tubes, so tubal pregnancy. Another relatively rare cause of salpingitis is the infection by Mycobacterium tuberculosis, so tuberculous salpingitis, which is rare as I mentioned, and often occurs commonly with endometritis, if you remember the lecture about endometritis. Other pathologies of the fallopian tubes include endometriosis, which is a serious disorder and a common disorder, but this will be discussed with the ovaries because that's where it occurs most often. Ectopic pregnancy, and I have to mention that primary tumors of the fallopian tubes are relatively rare, so adenocarcinoma in the middle portion of the fallopian tube is relatively rare, can occur, but most of the most common surface ovarian epithelial malignancies, high-grade serous carcinomas of the ovaries, derive from the fimbrial edge of the fallopian tubes. So these are of fallopian tube origin, but these tumors are discussed as ovarian carcinomas later in this lecture. So I will speak about ectopic pregnancy in general and include tubal pregnancy in this part of the lecture. So ectopic pregnancy refers to a pregnancy outside of the uterine cavity. This may occur in about 1% of all pregnancies, and of these ectopic pregnancies, tubal pregnancy represents the most common phenomenon. About 90% of ectopic pregnancies are of tubal localization. A special type of tubal ectopic pregnancy is the interstitial pregnancy, which involves the intrauterine portion of the fallopian tube. Then ectopic pregnancy can occur in the ovary or in the abdominal cavity. Generally speaking, in ectopic pregnancy, the early development of the embryo and the hormonal milieu is normal, which means that the placental tissue, the amniotic sac, the decidual changes all occur, but the ectopic site is suboptimal for the development of the complete fetus and pregnancy. Abdominal pregnancy can occasionally be carried to term, but this is obviously a suboptimal condition again and is prone to complications. Predisposing factors to ectopic pregnancy are mostly related to factors which inhibit the passage of the ovum from the ovarium to the uterine cavity. And these include pelvic inflammatory disease, so salpingitis, chronic salpingitis of gonococcal or non-gonorrheal origin. Then we have intrauterine tumors, for example leiomyomas, as I mentioned, can obliterate the orifice of the fallopian tube. And we also have endometriosis to be discussed later on, which may also impact on the passage of the ovum. So these are predisposing factors which can be recognized, but in about half of the cases no such anatomic factors can be demonstrated. The diagnosis of ectopic pregnancy is a diagnosis of pregnancy and the lack of identification of the pregnancy in the uterine cavity. So there are elevated levels of HCG, human choriogonadotropin, and this results in positive pregnancy tests. Even if this is not that elevated, that's not enough to disclose ectopic pregnancy. In the curettings of the uterine corpus of the endometrium, we see changes associated with pregnancy, so the decidual change of the stroma and the Arya-Stella reaction of the endometrial glands, but obviously as the pregnancy is ectopic, there are no chorionic villi or other fetal parts, so products of conceptions are missing from the endometrial curetting. In case of tubal pregnancy, the fallopian tube becomes dilated, distended. There is a cystic increase in size to about 3 to 4 centimeters in diameter, and this is often associated with clotted blood, hematosalpinx, and the placental tissue and fetal parts are identified within this distended, thin-walled part of the fallopian tube. For the diagnosis of ectopic pregnancy, we need to demonstrate the placental villi or fetal parts at an ectopic site. So in the endometrial curetting, we see decidual change of the stroma, and we see Arya-Stella reaction in the endometrial glands. This is a hypersecretory reaction with nuclear atypia. You can perhaps discriminate hyperchromatic large nuclei in this part of the gland. This is not to be mixed with neoplastic malignant atypia of the glands, and these two changes are seen, but no chorionic villi or other fetal parts are demonstrated in the endometrial curetting. In contrast, in the fallopian tube, we can identify the chorionic villi, syncytiotrophoblastic cells, hemorrhage, and decidual change in the stroma of the fallopian tube. As mentioned, clinically, most tubal pregnancies terminate with a bleeding, hematosalpinx, and these hematosalpinx, if the tube ruptures, can lead to hemoperitoneum and hemorrhagic shock and the death of the mother. So this is a prompt surgical intervention requiring emergency state. Pathology of the ovaries. We start with non-tumorous diseases of the ovaries. Cysts are common findings in the ovary. They originate from unruptured Graafian follicles or Graafian follicles that rupture but are sealed off immediately after. There are often multiple cysts in the superficial area of the ovaries in the subcortical region. These are filled with serous fluid. The lining of the cysts may be composed of granulosa cells, and then we speak about follicle cyst or follicular cyst, or they are lined by luteal cells, and then we speak about luteal cyst, cystic corpus luteum, or corpus luteum cysticum. These cysts may become large enough, may rupture, and rarely this leads to intraperitoneal bleeding, can even lead to acute abdomen, but this is a rare consequence of such cysts. You see a normal ovary with a Graafian follicle here, and here you see a part of a much larger cyst which has similar lining than the Graafian follicle, and you can appreciate at higher power that the cyst is lined by multi-layered granulosa cell, and this is diagnostic of a follicle or follicular cyst. Polycystic ovaries or polycystic ovarian syndrome or Stein-Leventhal syndrome is a condition that develops on the basis of excessive production of androgens by the deceased person, and this excess ovarian androgen production is of unknown cause. So there is excess androgen production which leads to higher level of androgens, but part of these hormones are converted to estrogens in the peripheral adipose tissue, and this will lead to the suppression of the secretion of FSH. So follicle stimulating hormone levels will be low in these patients, and luteinizing hormone levels will be high in these patients. Many of the symptoms of the syndrome are associated with the increased androgen levels. In these polycystic ovaries, the size of the ovaries become 3-4 times as large as the normal ovary. There are plenty of small cysts in the subcortical region, and between these cysts we see an increased amount of connective tissue. So stromal fibrosis is also a component of the polycystic ovarian syndrome. There are no corporal lutea, so there is no ovulation, there is no development of corpus luteum, and this is associated with infertility on the clinical ground. This is generally seen in young females following menarche, oligomenorrhea, sometimes amenorrhea may be a symptom, lack of ovulation, lack of corpus luteum formation. Hirsutism refers to the masculine type pubic hair and also a more male-like phenotype, often obesity, and associated with this type 2 diabetes also occurs as part of the Stein-Leventhal syndrome. Now we get to endometriosis, which is an important clinical condition and refers to the endometrial type tissue being outside of the uterus. Remember, adenomyosis was the invagination of the basal endometrium into the myometrium. Endometriosis refers to the presence of endometrial glands and stroma outside of the uterus. This is a common cause of infertility, pelvic pain, and other problems depending on the site of endometriosis. Endometriosis is often multifocal. It involves the presence of functional endometrium at ectopic sites, which is most common in the ovaries, but then can occur in the pelvis, less frequently in other sites of the abdomen, including bowels, the urinary tract. Rarely the lymph nodes, can be even found at distant sites like the lung. A specific manifestation is in laparotomy scares, like caesarean section scares. There are several theories to explain the presence of endometrium at ectopic sites. One of them is the regurgitation theory, which refers to menstrual backflow through the fallopian tubes and subsequent implantation of these endometrial tissues, for example in the fallopian tubes, the ovary, or the abdomen. The metaplastic theory refers to endometrial differentiation of the coelomic epithelium. The coelomic epithelium is prone for these metaplastic changes. This may also be endosalpingiosis, which is tubal type metaplasia, but endometriosis is also partly explained by such metaplastic changes. Vascular or lymphatic dissemination through these vascular channels or lymphatic channels would be a good theory to explain, for example, distant development of endometriotic sites or intranodal implants of endometriosis. And the stem cell or progenital cell theory would refer to bone marrow derived progenitor cells, which can differentiate it into several paths, and one of these would be differentiation into endometrial tissue. These theories explain part of the endometriosis phenomenon, but not all of them. They are not mutually exclusive. Some manifestations of endometriosis are better explained by one theory, whereas others are better explained by other theories. For example, the regurgitation theory is very good to explain ovarian endometriosis, but it would be very hard to imagine this as a possibility to explain, for example, intranodal or brain or lung involvement by endometriosis. The endometriosis contains endometrial tissue which is not just at the wrong location but is also abnormal in function. It has been demonstrated that there are increased levels of cytokines, inflammatory mediators like prostaglandin E2, tumor necrosis factor alpha, and so on. And there is also an increased production of estrogens by stromal cells, which contain the aromatase enzyme, which converts precursors to estrogens, and there is an increased amount of estrogen because of these cells producing the enzyme, and this increased amount of estrogen helps the endometriotic tissue to be maintained at the ectopic site, which is not the optimal site for endometrial tissue. As the endometrial tissue in endometriosis is functioning, it undergoes the cyclic bleeding, but of course it cannot be evacuated with menstruation because there is no way for that, so it remains there after bleeding, and it follows the degradation of blood, which by the end turns to hemosiderin and then becomes brownish yellow-brown in color. In the ovaries, the lesions are often cystic, and these are referred to as chocolate cysts due to the hemosiderin caused brown discoloration of the lesion. Endometriosis is often associated with widespread pelvic, or if this is the intestine which is involved, in intestinal fibrosis. Microscopically, endometriosis is characterized by the presence of three things, and these are demonstrated here. One of them is bleeding associated hemosiderin, which is located in macrophages and can be highlighted with the Prussian blue stain. And the other two components are the endometrial stroma, which stains positive with the CD10 antibody on immunohistochemistry, and the endometrial glands, which are highlighted here with the cytokeratin immunostain. When we have two of these three components, so hemosiderin, endometrial stroma, and endometrial glands, then the diagnosis of endometriosis is possible on clinical and pathological grounds. Sometimes we are not that happy to find all the three components, sometimes even not the two components, and then it makes the diagnosis difficult or just compatible with endometriosis. The clinical symptoms or manifestations depend on the site of endometriosis. A very common symptom is pain, especially pain associated with the menstrual cycle during menstruation. This is referred to as dysmenorrhea, intrapelvic pain associated with bleeding. A common consequence of endometriosis is related to fibrosis and scarring. This is leading to sterility. This is a predisposing factor for tubal pregnancy. If it involves the bowels, it may lead to blood in the stool, may lead to bowel obstruction. If it involves the urinary tract, it may lead to hematuria or urinary tract infections, obliteration, and so on. So the manifestations are multiple, and this is a serious condition, quite often challenging for treatment. We get to the tumors of the ovary, and the tumors are classified according to main streams into three large categories: the coelomic surface epithelium derived tumors, germ cell tumors, and the sex cord stromal tumors. And we have a fourth category for metastatic tumors, so secondary tumors of the ovaries. The surface epithelial tumors are the most common ones. These are classified according to biological behavior into benign, borderline and malignant tumors. The benign are often cystic, so they are cystadenomas. Borderline tumors show an increased proliferation of the epithelial cells. They can also be referred as tumors of low malignant potential, but the WHO classification prefers the borderline nomenclature, and malignant tumors are the carcinomas, which may be cystic quite commonly, so then we call them cystadenocarcinomas. According to the epithelial cells which make up the tumor, they are histologically classified into different types, the three most common being serous, mucinous and endometrioid. The others will not be discussed here. Malignant forms of these surface epithelial tumors compose 90%, so the majority of all ovarian malignancies. Predisposing factors include nullipoity, and there is also an association of serous tumors with the germline mutations of the tumor suppressor genes BRCA1 and BRCA2, some other prefer to say BRCA1, BRCA2. These germline mutations are associated with hereditary breast and ovarian cancer syndromes. Benign serous tumors are cystic most of the time. These are cystadenomas. A few of them, 25% of them, may be bilateral. The inner surface is smooth. Rarely some papillary projections may be seen, but by majority they are smooth inside, and outside they also show a smooth and glistening surface. They are lined by a single layer of columnar cells which may be ciliated quite commonly. Sometimes we see secretory cells in them, but they are not mucinous secretory cells. Papillary formations may sometimes occur, and even some more bodies, so special type calcifications can be seen in association with the papillary projections. Borderline tumors are defined by an increased proliferation of the epithelial cells without stromal invasion. Stromal invasion is the phenomenon which distinguishes malignant tumors from the others, so invasion of the stroma is the diagnostic criterion for serous carcinoma. Of course, there are other signs of malignancy like cytological atypia, sorry for the typographic error, multilayering of the cells, so increased cell proliferation, which is often of the papillary type. You can see that these tumors, serous carcinomas, cystic, so cystadenocarcinomas, are often bilateral, involving both ovaries, and these are the most commonly bilateral tumors. The inner surface of these tumors is characterized by warty or papillary growth projections. There may even be solid areas, and the surface is irregular because of these proliferations and projections. We will see this on the gross image. There are two types of serous carcinomas, the low grade and the high grade. These reflect different pathways and different biological behaviors as well. So the low grade serous carcinomas derived from a pre-existing other tumor, which is often of borderline malignancy but may also be benign. So this is a long, slow progression with the involvement of the KRAS, BRAF and ERBB2 oncogenes. In contrast, the high-grade serous carcinoma is a rapidly progressive tumor which has no previous pathology, so no borderline or benign tumor in the history, and these often harbor mutations of the TP53 gene. This is a serous cystadenocarcinoma. You can see the tube, and this is a very large mass tumor, which we cannot see whether this is cystic or not, but if we make a cut surface, it turns out to be cystic with plenty of papillary ingrowth, which makes the surface irregular. In histology, we can identify atypical cells lining the cyst. We see glands within the stroma. This is stromal invasion, and in this specific tumor we also see these basophilic areas which correspond to calcification. Serous carcinoma most commonly spread contiguously to the peritoneum, so peritoneal involvement of the pelvis and the abdominal cavity is the most common spread of these tumors and the most serious consequence. Sometimes, not uncommonly, we also see regional lymph nodal metastases, but distant metastases are relatively infrequent. They occur into the lungs or the liver. The prognosis depends on the grade of the tumor and also on the stage of the tumor. Most of these tumors are unfortunately of advanced stage when discovered. Mucinous tumors differ from serous tumors in a number of things. Most mucinous tumors are benign. They are lined by a specific type of epithelium producing mucin. The cyst content is mucinous, either a sticky fluid mucin or a gelatinous, more solid secretory material can be seen in the cysts. Only 5% of the malignant tumors are bilateral, so when we speak about bilaterality, we will see that metastatic tumors are commonly bilateral, but of the primary tumors, serous carcinoma are the most commonly bilateral in about 2/3 of the cases. We will see that endometrioid tumors are bilateral in about 1/3 of the cases, and these are bilateral very rarely. When we speak about mucinous tumors, we have to mention the condition pseudomyxoma peritonei in association with them. Pseudomyxoma refers to the formation of mucin in the abdominal cavity on the serosal surfaces. If we speak about pseudomyxoma, we cannot identify the tumor cells within this mucin, but we see a mucinous ascites. When we see the tumor cells, then it is the metastasis of a mucinous carcinoma. Most cases of pseudomyxoma peritonei are not related to ovarian tumors, but are coming from low-grade malignancies of the appendix. This is the picture of a cystadenoma of the mucinous type. This is multicystic, and you can see the gelatinous content does not get out of the cyst, whereas the sticky mucinous fluid can flow out when you cut on the cyst, and the lining is a mucin secretory single cell epithelial layer. Endometrioid tumors resemble to the endometrium. Most of these tumors are malignancies, so endometrioid carcinomas, but of course benign and borderline forms can also occur. They are bilateral in about 1/3 of the cases, as mentioned previously. If there is no associated endometrial cancer, then they are primary ovarian tumors, but in about 15 to 30% the patients also have a concomitant endometrial carcinoma. It has been long discussed whether these are metastatic or synchronous tumors, all primary in the endometrium and the ovarium, but now there is genetic evidence gained with comparative genomic hybridization that those tumors which have endometrial and ovarian components are most of the time metastasis, ovarian metastasis, transtubal metastasis of the endometrial carcinoma. Not only the morphology of primary endometrioid tumors is identical with endometrioid tumors of the uterus, but even the loss of function PTEN mutations are common. Germ cell tumors are the third category of tumors to be discussed. The most common of these germ cell tumors is a teratoma, which is a benign major teratoma called the dermoid cyst. Other rarer tumors have malignant features and include dysgerminoma, which is the ovarian counterpart of the testicular seminoma. So they are identical in morphology, but their name differs on the basis of location. In the ovaries they are termed dysgerminoma. We also have embryonal carcinoma, choriocarcinoma, and yolk sac tumors. Choriocarcinoma, remember, can be of primary ovarian germ cell origin. We will see another type of choriocarcinoma later in this lecture. So let's get to the teratoma and the dermoid cyst, which is a benign tumor derived from totipotent germ cells and showing an ectodermal differentiation. The name implies that it resembles the skin. And indeed, the lining is like the epidermis, with skin adnexal appendages being included. Most of these tumors occur in young women. The cysts are filled with sebaceous material and matted hair. They are disgusting. They are nasty looking, ugly tumors in terms of growth pattern. As concerns the microscopy, they are very, very interesting. Many of these tumors can have a nodular thickening in the wall, and within this thickening there are several different types of tissue which can be identified. Quite commonly we can identify teeth in these protruding nodules, but we can identify bone, cartilage. We can even see bronchial, gastrointestinal epithelium, but even glial differentiation can occur in these areas. Rarely, as a complication of teratoma, we see malignant transformation. This occurs in 1 or even less than 1% of the cases and is generally a squamous cell carcinoma developing from a dermoid cyst. This is how the dermoid cyst looks like. So it is full of this yellowish sebaceous material with the hair included. This is the content of the dermoid cyst, plenty of hair and this yellowish smelly material within it. So they are disgusting. In terms of histology, you can see the typical lining is reminiscent of the epidermis. You see plenty of sebaceous glands. This is part of a hair follicle, and even sweat glands can be seen and in different parts we can see different other tissues as well. Now we get to the third category of primary ovarian tumors, and these are the sex cord stromal tumors, which may differentiate either towards granulosa and theca cells like the normal ovarian stroma, but may also demonstrate Sertoli or Leydig cell differentiation. These latter will be associated with androgen production, whereas granulosa cells will produce estrogens. And on the basis of this hormone production, there may be hormonal symptoms associated with these tumors. Most of these tumors, so about 2/3 of them, occur in elderly postmenopausal women. They must be all considered potentially malignant, even if they do not show the features of histological malignancy. The clinical behavior or features, symptoms, are very commonly associated with hormone production. Excess estrogen production may lead to precocious sexual development if occurring in the young, but commonly in the postmenopausal age group they result in endometrial hyperplasia. Remember that this is associated with excess estrogens, endogenous or exogenous, and by this is also an association or predisposition to endometrial carcinoma through the increased amount of estrogens. This is an example showing granulosa cells. This is from a granulosa theca cell tumor. Sometimes we can identify that the tumor cells try to form cysts. These are referred to as the Cole-Exner bodies, and their presence help the pathologist to identify the tumor as a granulosa cell tumor. Metastatic tumors of the ovary are commonly bilateral. They come from gastrointestinal tumors or abdominal tumors, may include the pancreas as well, and breast tumors, especially lobular carcinomas, are prone to metastasize to the ovary. The Krukenberg tumor is a clinical manifestation of bilateral ovarian metastasis, and this is a metastasis coming from a gastric cancer of signet ring cell type, poorly cohesive carcinoma as they say nowadays. This is characterized by the presence of these discohesive secretory tumor cells. In this example there are plenty of them. They secrete mucin, which can be highlighted with the PES stain, and the cytokeratin immunohistochemistry also highlights these tumor cells. Often the stroma shows a very strong reactive proliferation, sarcomatoid, resembling sarcoma but not being malignant, and this may hide the tumor cells which are responsible for the stromal reactions. This is a very cellular example of a metastasis, but sometimes we are not so lucky with the identification of metastatic tumor. Sometimes the tumor cells are very sparsely distributed and the stromal reaction is what we see at the first approach, and then we need these special stains to demonstrate the metastatic cells. So the lesions we have discussed in the tubes include salpingitis, we mentioned tubal pregnancy, and we mentioned endometriosis, also mentioning serous tumors, high-grade serous tumors of the ovaries being derived from the fimbrial edge of the tubes. In the ovaries we discussed cysts, the polycystic ovarian syndrome, endometriosis was discussed in details with the ovaries, and of the tumors we discussed some epithelial tumors, benign, borderline and malignant in behavior, the serous ones, the mucinous ones and the endometrioid ones. The germ cell tumors were mentioned and the dermoid cyst was discussed in more details. Sex cord stromal tumors were mentioned and the metastatic tumors. Before closing the lecture, there are some things about pregnancy related pathology which need to be mentioned. We start with inflammatory conditions. These are infections of most commonly ascending infections which come through the birth canal. Most commonly they are caused by bacteria, although they may be caused by intracytoplasmic agents like Mycoplasma, Chlamydia or Candida as fungal in origin. They can cause premature birth or even abortion. They lead to the rupture of the membranes, and this is how abortion or premature birth develops. A key feature is the inflammation of the chorion and the amnion, commonly called chorioamnionitis. There are neutrophilic granulocytes involving these structures with edema and hyperemia, active hyperemia. The infection may involve the cord, which is referred to as funisitis, which is not described here, and may also involve the placental villi. So ascending infection is the common cause of chorioamnionitis, but sometimes it is derived from a hematogenous spread of the infection, which is relatively rare in comparison to the ascending infection. Here, villitis, inflammation of the villi, is the first thing to occur. The underlying conditions, the causes, include syphilis, tuberculosis, listeria infection, toxoplasmosis, and even viral infections may occur. Rubella cytomegalovirus or the herpes simplex viral infection may be causes of placental inflammations and fetal pathology, pregnancy-associated pathology. Ectopic pregnancy was discussed earlier, and then we get to the category of gestational trophoblastic disease, which includes a number of trophoblast-related proliferative disease, tumor-like or tumorous conditions of trophoblasts. Not all of them are going to be discussed. The most important form or the most common form is the hydatiform mole, of which two different types can be distinguished. One is the complete mole, the other is the partial mole. In terms of morphology, the complete mole has no fetal parts and involves all chorionic villi which are abnormal. The partial mole has some normal villi, so there is only partial involvement of the villi and can contain fetal parts. As concerns the pathogenesis and the genotype, these are also different. The complete mole is diploid, more commonly has 46XX genotype, and is the result of an empty ovum being fertilized by a single sperm which divides subsequently, or sometimes two sperms. This latter may lead to the 46XY genotype. In contrast, partial moles have a maternal chromosomal set and have two paternal sets of chromosomes, and therefore are always triploid. In the hydatiform mole, the uterine cavity is filled with grape-like structures, which are not different, which are representing cystic dilated chorionic villi. So they are as big as about half or 1 centimeter in size. They are cystic, degenerated chorionic villi forming these grape-like structures. The complete mole involves the hydropic swelling of all chorionic villi. there is practically no maternal vessel seen identified in this villi, and there is a circumferential diffuse proliferation of trophoblastic cells, cytotrophoblast and syncytial trophoblast. So this is diffuse and circumferential. In partial mole, this is partial partly because only some of the villi are showing these morphological changes, and the proliferation is also focal and not circumferential. So the hydatiform mole is characterized by this cystic hydropic degeneration showing chorionic villi, which in the case of the complete mole show a circumferential proliferation, excessive proliferation of trophoblastic cells. Hydatiform moles have two peaks in age for the incidence. One is in the young, early age pregnancy, before the age of 20. The other is late pregnancies after the age of 40. The usual presentation is bleeding from the vagina after conception, about 12 to 14 weeks after conception. The uterus becomes enlarged, and no fetus can be demonstrated with ultrasound or physical examination. The pregnancy-related HCG levels are high. The clinical course of hydatiform moles includes their becoming invasive. In about 10% of the cases, there is an invasive mole which develops. We will discuss this later, and it may also give rise to gestational choriocarcinoma in about 2 to 3% of the cases. Monitoring of the HCG levels helps to follow up the moles and to identify progression. We will speak about the role of chemotherapy on a later slide. So invasive moles are characterized by the invasion of these degenerated villi into the myometrium. Even embolization through the vessels may occur. There is no formation of metastatic nodules, but there may be small foci of necrosis due to the embolization process. All invasive moles are associated with an elevated level of human choriogonadotropins, and these are removed either surgically, or if the patient is young and wishes to have further pregnancies, then chemotherapy may be used, and this is often effective in the treatment of invasive moles. Invasive moles can turn into choriocarcinomas. Choriocarcinoma develops more often from complete moles. Very rarely it can be a consequence of partial moles, but gestational choriocarcinoma may also occur after abortions in about 25%, and the rest, the other 25% of gestational choriocarcinomas, are seen after normal pregnancies and deliveries. Therefore, after pregnancy, HCG levels must be monitored for the disclosure of choriocarcinoma. These tumors are very much prone to necrosis and hemorrhage. Sometimes it is very difficult to identify the tumor cells within the hemorrhagic and necrotic areas. They invade through the walls of the uterus. Vascular invasion and dissemination are seen relatively early. Choriocarcinoma lacks villi, so unlike invasive moles, there are no villi identified. There are just trophoblastic cells, atypical tumorous proliferation of trophoblastic cells. Clinical features involve discharge, bleeding or brownish discharge from the uterus, a very high level of HCG, which is maintained after pregnancy or abortion or the evacuation of the mole, and as mentioned earlier, widespread dissemination, hematogenous dissemination, may be a feature of choriocarcinoma. Luckily enough, chemotherapy is efficient in the treatment of these tumors, and nearly 100% of them can be treated even after dissemination. And there is a role of the maternal immune response against paternal antigens, which helps treatment to be so effective. By contrast, choriocarcinoma of non-gestational origin, so primary germ cell ovarian tumors showing choriocarcinomatous differentiation, are resistant to chemotherapy and are of poor prognosis. This is a picture of choriocarcinoma, no villi identified, trophoblastic cells. Obviously you cannot see that these are trophoblastic cells. This can be proved by immunohistochemistry, but these are very atypical trophoblastic cells which characterize choriocarcinoma. No necrosis and hemorrhage on this picture, but often the case in this tumor. Thank you for your attention.